So for everybody out there that's watching today, hi everybody, good morning. Good morning. Thank you. So welcome to our 33rd program of this year. Amazing considering we did 31 all of last year and we still have another 6 to go. But good morning and welcome to this MS Views and News Annual Symposium. And for those that don't know, this is already our 5th annual symposium. So again, I want to thank you all for being here. We have a very good crowd here today and I'm really happy to see all these tables nice and full. And we have a lot of people that are watching this on live stream today and I'm thankful for all of you too. So I'm saying hello and thanks for being here. Before I continue, I want to thank for the opportunity to give to our sponsors and those that gave us education grants to do this program. Because without their assistance, these programs that we do is not possible. So, firstly, I want to thank Genzyme, a Santa Fe company, who's the maker of Aubagio. We want to give them a round of applause and thank them for doing this for us today. We also have Mallinckrodt Pharmaceuticals, also previously known as Questcor Pharmaceuticals. They make the Acthar gel that's used for many of you who have relapse. Teva Neuroscience, the maker of Copaxone, who now switched to that 3-day-a-week formula. It's the 40-milligram formula. So we want to thank them for all their help. Genentech, who's a company that none of you know the medication of yet. They have something in the works, hopefully an emerging therapy, and you'll hear about it today from our speakers. Also, other sponsors are Neuroscience Centers of Florida Foundation, Accorda Therapeutics, Biogen IDEC, Bionis, Pfizer, Infinity Research, and Neuroscience Consultants. Again, let's give them all a round of applause because we cannot do these programs without them. And believe me, they want you to learn. Okay, they are helping us because they really want you to learn more about MS. They want your caregivers knowing about it. So, again, I thank them for all they're doing. So, as we continue, yes, we obviously know there are a lot more questions to be asked from here as well as our internet audience. And please just write down your questions. Give it to me or somebody else from MS Views. They're all walking around with green shirts. You can find us easily. Anybody on the internet that has questions, please send email to us from our website. We will get the doctors to answer this, and we'll post up all the answers on our website. So now we're going to get into the next set of speakers. We have Dr. Rick Harris, who's here, and Dr. Rick Harris is going to be speaking with you. I don't know where he's at. Where is he at? But he's going to be speaking with you about the Neuro-Psych testing here. Dr. Rick Harris, I forgot he's only that high. So Dr. Harris is going to speak to you for approximately 25 minutes, and we're going to cut him, get him down, and get the disability attorney up here, and she'll speak for a little while, and then we'll get into Q&A for them as well. Thank you.
Hi, good afternoon, everybody. I've always been told that it's a disadvantage to talk to y'all during lunch. So I'm hoping that this is going to be interesting and exciting for you to keep your attention. If I see any of you with your eyes slowly closing, I'll be throwing darts at you. First of all, I wanted to thank Stu for this and MS Views and News for this opportunity to talk to you. What I'm hoping to do is to talk about how MS affects each and every one of you. I'm also hoping that we can talk about how do we evaluate that effect on us? How do we truly understand what those effects are on us? And the last part of my talk is going to be, what can we do about it? And I'm a little technologically challenged, so we'll try it. Okay. So the first thing that I wanted to talk about is certainly the first couple of presenters talked about what happens in the process of MS and how it really affects brain functioning and neurons and central nervous system, and how it's an autoimmune disorder that affects the myelination of the nerve cells. We all know that you all can go get an MRI and look at the effect of MS on brain structure. how is MS affecting our brains? MRIs show that, but the one thing they don't show is how our functioning is affected by the MS, by the lesions, by the demyelination. The MRI doesn't tell us how does that affect us. There is a technology called SPECT scans. SPECT scans are single photon emission chromatography. How many of y'all heard of SPECT scans? Has anyone in the audience ever had a SPECT scan? No. Daniel Amen is a neuropsychiatrist who's done over 90,000 SPECT scans in the country, and I've worked with Dr. Amen, and unfortunately I was going to show you some scans of MS patients so you can take a look at brain functioning. What happens with a SPECT scan, it's an opportunity to look at how MS affects brain functioning. And what you're looking at on the slide presently is a SPECT scan. And what it does, it looks at brain functioning. And let me see if I can find, I apologize for this. So this is a sample of a scan of an MS patient with SPECT scan. And what you can see is the areas that are in red are areas that are not functioning up to par. This is a two-dimensional. We also have three-dimensional representations of that. Again, this is the side view of an indication that those particular areas of the brain that are lit up in red and white are not functioning. However, this still does not tell us how MS affects each and every one of you. All this lets us know is that compared to a healthy brain, this brain is not functioning adequately. So how do we take a look at? How do we look at what's happening with the individual? Okay, first of all, how many of you in this room, and give me a show of hands, have experienced cognitive changes with your MS? Okay, quite a few. And what we find out is that 43% to 65% of all individuals suffer from cognitive changes. Okay, and when we look at MRI, they're not necessarily correlated with those cognitive changes. There's real MRI variability, structure, and function are two different things. 80% of all MS patients are mildly affected by their cognitive abilities. And we know that sometimes you're affected by who you are, how you handle these changes. So if you were to come to my office, okay, and I said to you, okay, you're telling me you have cognitive changes. We want to take a look at what those changes are. So I want you to imagine we can do what's called a neuropsychological evaluation. How many of y'all have heard of a neuropsych or had a neuropsych evaluation? Okay, good. So what we would do in a neuropsych evaluation, is an attempt to look at the effects of MS on you as an individual, how it has affected you. We're looking at behavior, and we're making inferences about your brain's functioning. So it's brain-behavior relationships. So if you were going to come to an office for a neuropsych evaluation, the first thing we would do is you'd walk into my office, and you would look at my couch, and I go, no, that's not for you. That's for my other patients. You need to come sit at the desk. And the next thing we would do is we get a complete history. I'd want to know what's going on. I'd want to know a little bit about your past. How far did you go in school? Did you graduate school? Did you have academic problems? What's your occupation? Has there ever been a head trauma? And has there ever been, have you ever been unconscious or extreme high fevers? The next thing we're going to do is going to ask you individually what your symptoms are. What are your cognitive impairments? Okay? How has MS affected you? And help me out. Just someone tell me what are some of the cognitive impairments that you've experienced? One woman says that her cognitions or cognitive is getting worse. But what are some of the symptoms that you experience? Forgetting words. Okay, absolutely. What else? Any other? Bad memory. Excellent. Absolutely. So we can have memory problems. We can have attention problems. We can have planning and problem solving, what we call executive functioning. We can have information processing problems. We can have word finding problems. And we can have visual hand coordination problems. These are all very common. So in a neuropsych evaluation, what we would do is we would ask you, what are those symptoms? Okay, but the problem we have is we don't know. How bad are those symptoms? We don't know the real causes of those symptoms. Certainly, depression can affect our memory, can affect our attention. Did you have attention deficit disorder as a child? We're not sure exactly what the causes are. And the worst thing, the worst word we can use is with the aging process, we don't function as well cognitively. So when we do a neuropsych evaluation, the first thing we're going to look at is we need to help with the diagnosis. Is those symptoms that you experience really part of the MS, or were they predate the MS? We also look at what are your strengths and weaknesses. We also, important to establish a baseline. A neuropsych can be repeated over numerous times so that we can see how you're doing. Are you getting worse? Are you staying the same? The most important thing is we use a neuropsych evaluation to plan treatment and help you compensate for your deficits, for your weaknesses. So often I'm asked, what do we test? What are we looking at in a neuropsych eval? We're looking at memory. We're looking at attention. We're looking at executive function. We're looking at abstract reasoning. And a neuropsych eval is tailored to each and every individual. And what we do is we compare your results to a healthy average individual. That way we get an idea of how you compare to others. We also compare you to yourself. We're able to make inferences based on neuropsych testing how you were before you contracted MS and before you started to have deficits. So the comparison is between yourself and other people. And the most important thing is to help us make specific recommendations on what you can do. It also can help if you're filing for disability. And we're going to, we'll talk a little bit about that in a bit. But it can also help you because you can quantify or objectify your disability by having an actual score. All of the neuropsych testing are standardized scores. All right, so what can we do to manage neuropsych deficits? What is it you can do to manage these cognitive deficits? How many of y'all have heard of biofeedback? Okay, if anyone in here ever participate in biofeedback? Okay, let me share with you. This is some really exciting work that we've been doing in the practice for the last 15 years. Biofeedback is a process of feeding back to us biological information not normally in our control. Okay? The simplest form of a biofeedback instrument is a heart rate monitor. I can hook you all up to a heart rate monitor, which measures beats per minute, and say to you, I'd like you to lower your heart rate. By just having that feedback, your brain can learn to lower the heart rate because it's feeding back to us an unconscious process that we're not normally considered under control. So what would you say to me if I said to you, guess what? I can improve your brain functioning. I can help your brain function up to its potential. I can improve its functioning. I can't heal the demyelination, but I can help it work at its best. We can improve brain functioning by feeding back to you brain's information. Neurofeedback is what is called a form of biofeedback, or EEG biofeedback, or neurotherapy. It was started in the 1970s, and it was an interesting phenomenon that occurred. There were research being done at that time, back in the days when meditation was being studied, and neurofeedback was used to produce what we call a meditative state. We'd measure someone's brain activity, and we would feed it back to them when they entered what was called the alpha state. A researcher back then was doing a study with cats, teaching them how to meditate. Not that cats necessarily need to meditate, but that's how we did research. He made a mistake, and he also got a Defense Department grant to study the effects of nerve gas. He used some of the same cats, and what he found was the cats that had done neurofeedback did not experience seizures when they were exposed to neurofeedback. So his research assistant, his doctoral research assistant, was a woman who had a treatment refractory seizure disorder. And she said, treat me, treat me. That was the beginning of neurofeedback used in a clinical setting. So real simply, what happens in neurofeedback, the brain produces electrical activity. Okay, we produce brain waves, delta, theta, alpha, beta brain waves, and we do this no matter what the insult is to the brain. And we also know that within those brain waves, we can have dysregulation. And dysregulation can occur because of the demyelination process. We can have dysregulation of arousal states, instabilities, and disinhibitions. And what we do with neurofeedback is we literally measure the electrical activity of the brain. Nothing goes in. We place the electrodes based on your symptom profile, based on the results of the Neuro-Psych evaluation, and we program into our computer 2 targets that we want your brain to achieve. We want your brain to be stable, okay, no instabilities, and we want it to function at its best. And when your brain achieves that, we feed it back to you. And we feed that back to you. What do? You watch a movie. And the movie does this. And when the movie screen is big, it says to you that your brain is in the right zone. When the movie screen is small, it says to you, you're not in the right zone. So literally what we're doing is we're twisting the arm of the brain to improve its function and to improve and to heal itself. And what we find is that there's an increase in attention, focus, memory improves, sleep improves, okay? So we're teaching this brain how to improve its own functioning. And just so you know, what can we help with neurofeedback? Attention problems, headaches, addictions, sleep problems, depression, panic attacks, chronic fatigue, autoimmune dysfunction, ringing in the ears, and specific learning disabilities. We have found the results of neurofeedback, and the research is really strong in this. To be really, really strong, we've treated a number of MS patients in the practice. We see that we help with symptom management. We help improve brain functioning. We see results when we go back and test their attention and concentration, that there's improvement. It's brain exercise. All righty. Thank you.
Our next speaker is Lisa Goetz Gonzalez, and she's a disability attorney from Weston. And Lisa's coming up now. And after Lisa speaks, we'll have Q&A for both of them.
Hi. Good afternoon. Thank you for inviting me again to the MS Symposium. Stuart, you've done a great job. Thank you. This cause is true to my heart, so very happy to do this. I'm going to be talking about Social Security disability and how to build a case if anybody is applying for disability or getting reviewed. I'll be happy to answer any questions afterwards. Let's see. There are two main programs for Social Security disability. There's Title II, which is known as Disability Insurance Benefits, and there's Title XVI, which is known as Supplemental Security Income. Both programs differ quite drastically in terms of financially what you need to be able to qualify for one program or another. But in terms of what you have to prove to be disabled, those things are the same. Just to get an idea of the audience, how many people are currently on disability? Okay, and how many people are applying or in the process of appealing a Social Security disability claim? Okay, and how many people have been receiving benefits and have either been working or have received reviews from the Social Security Administration to see whether or not they should be continuing benefits? Okay, so I'm going to touch briefly on that because they are doing reviews. But for Social Security disability, you have financial requirements that are required for Title II benefits. If you've worked and paid money into the system, you would be applying for Title II benefits. If you have not worked, you would be applying for Title XVI benefits. Title XVI benefits has the added burden of showing financial difficulties, stresses. You have to meet the poverty line. Sometimes you may have worked, paid money into the system, have enough quarters of coverage, but the earnings that you made were not enough to bring you on a monthly income above the poverty line. So in those cases, they're called SSDC. They're concurrent cases, but basically they touch on both cases, disability insurance benefits and supplemental security. Normally people just say SSDI, but they are a term of art, and when you apply at your local office, they will file for the application that you would qualify for. The Social Security disability definition. The disability definition is written in stone. It was established by Congress. It is when you are unable to work and perform substantial gainful work activity for a period of 12 months or more. It also can be if you have been unable to work and not perform substantial gainful work activity due to a medical impairment that will result in death. So if your condition is severe enough, it would be considered an emergency situation and they try to push it forward. But either way, you have to meet the criteria of being unable to work because of a medical impairment, and it's likely to maintain and continue 12 months or more continuously. There's a step 5 process, which is a simple evaluation, but every step is not as simple as it seems, but I'm going to touch on it very quickly. I do not have it on the slideshow. I do mention it though. One is step 1, are you engaging in substantial gainful work activity? If you are working and you apply for Social Security disability and it's considered to be substantial gainful work activity, you are denied benefits. If you are not working and you apply for Social Security disability, you go to step 2. Step 2 determines whether or not your condition is severe. Severe is a term of art, and as far as I'm concerned, any condition that has brought you to the Social Security office to apply, in your estimate, is severe. So if it's severe, we go to step 3. If Social Security finds that your condition is not severe, you get denied. At step 3, they try to figure out whether or not your disability meets or equals a particular listing of impairment. MS has several listings, and I'm going to go forward for the second part, talks about the criteria of impairments. So MS has several different criteria, but for that you need a lot of medical records, a lot of objective medical tests, be that MRIs, CT scans, blood tests, medical records, documentation of all the non-exertional impairments, which would be fatigue, tiredness. So they're going to see whether or not you qualify for these listings that Congress has brought out to mean you are disabled. If you meet or equal the criteria of disability under Social Security guidelines, you are allowed benefits and your case should be won. This is normally done at lower levels, at the initial level or at a reconsideration level. However, most cases go before an administrative law judge or above, and in that case, it was because step 3 was not met, and they did not find that your condition, even though diagnosed with MS, would meet or equal the criteria. If it is found to not meet or equal the criteria, Social Security must go to step 4. At step 4, the question is whether or not you have a residual functional capacity to perform your prior work. If you could perform the work you used to perform, Social Security must deny your claim. If you are unable to perform the work you used to perform, Social Security will then determine whether or not at step 5 you're able to perform any other job in the national economy. That's where most of the cases are heard and won at the administrative law judge level. So Social Security has these step 5, it's called a step 5 sequential evaluation. You can find it online, you can ask me about it. Feel free to email me with any questions, I'll give you my email. But really those 5 considerations are established by Congress and those don't change. So I'm going to go back to slide 3, which is how, I think this is slide 3. I'm sorry, slide 2? Slide 3. Okay, so disability and the definition is an inability to work on a substantial gainful work activity due to a medical impairment. And then this is a blurb about the step 5s, but the step 5s were a little more detailed when I explained it. Are you able to do your past relevant work? Past relevant work is defined as any work you did 15 years prior to the date you last worked. 15 years prior to the date you last worked, not the date you get diagnosed, not the date you go to a hearing, but the date you actually last were able to work, and then they go for the last 15 years and consider all that to be part of the term of art, which is called past relevant work. Then the question is, if you're not able to go back to the past relevant work, which was step 4, at step 5, would you be unable to transfer or adjust to any work in the national, regional, or local economy? And all of them are fair game. So if you were to want to say, I'm not able to drive to work, or that job is in California or in Memphis and I can't leave, that's not a consideration. Social Security is a federal program. So if it's available in the national, regional, or local economy, an ALJ, an administrative law judge, can find that you are able to work and can deny your case. And then again, the disability has to be expected to last for 1 year or result in death. This is the proper preparation for a case, and I think all of the doctors that spoke earlier are touching on exactly what you need. More than anything is you need a doctor that's going to be on your side. It's part of patients' rights. 2 years ago when I spoke at your conference, I talked about patients' rights. I believe it's in the website. It's very detailed about the relationship you have with your doctor and what you need your doctor to be able to corroborate and write in their reports. So as an attorney or representative, because you don't need to be an attorney to go into Social Security and represent a person, you want to make sure that the case is properly prepared. You want to make sure that your medical records are up to date and concise. You want to make sure that all of your complaints are properly documented. So even if you have a day that you feel well and you go to a doctor and you say, I'm having a good day, that's great, but that's what the judge is going to read. And they're going to say, oh, you're having a good day. You've been stabilized, and in good days, what do you do? So it's important when you see your doctors to explain, a good day for me means I can get out of bed. I can return phone calls. I can have a conversation and not be in bed. I can do what normal and able-populated people do, able-bodied people. I can actually take a shower and maybe go out and socialize a little bit. Document exactly what it means, because it doesn't necessarily mean that because you had a good day, you're able to get ready, go to work, schedule the time that you're going to be in and perform work, which is considered 40 hours a week on a sustained basis. Your impairments are only supported by your testimony when you get to the appeals, to the judge's level. So you go up to a judge, and it is your opportunity to talk to a judge and say, my medical records weren't enough. So now I'm here to talk about and explain and support all of these medical records. So having a nice relationship with your doctor, getting the tests that you need, your MRIs, your TC scans, your bloods, all of those get evaluated. All of those are invaluable. One of the doctors, I think it was Dr. Steingo, who said, it's important that you take your medication. It's also important that you record when a medication is changed. So you may be able to be on the same medication, but if your dosage was increased by milligrams or by frequency, that's very important, because that shows that your condition is not stable. There have been changes, and these subtle changes are then brought up at the hearing level. Very, very important. The 5-step sequential process, which we talked about, all of this interplays. So when you see that wheel, it's really the proper theory of the case. As an attorney, I particularly don't go in and say, my client meets the listing of impairment, they have MS, we have these records to support. Because, first of all, if it had been that clear-cut, you would have been awarded benefits at a lower level. If we're in front of a judge, it's because it's a credibility issue. And now I feel that you need to come and corroborate these evidences, these medical records, and you need to testify as to your activity of daily living, how you spend your day, how you wake up, how you don't sleep, how many fevers you have, how much depression you may have or anxiety because of your condition, what doctors you're seeing for the medical that's mental as opposed to just for the physical part. And we put it all together into a proper theory of the case, and we weave it, and it's not as simple as, I think, and I've been very successful arguing, I don't believe it's as simple as saying, this is a diagnosis, this is a test, they qualify. We put everything together in a theory. So one of the most useful tools that may not be consistent because Social Security is a lengthy process, it's a many times humiliating process. One of the main things that I say is keep a journal because it's an administrative court proceeding. It is automatically included into evidence. The evidence laws of circuit court, federal court, don't necessarily apply in these administrative proceedings. They're meant to try to really bring out how that individual is on a daily basis and why this person really feels that they're not able to perform a 40-hour work week consistently. Journals are a great way to do that because you submit them into evidence. They can have a year and a half of entries, whether it's every day, every month, and it gives a nice system of how this person is living. And outlining the preparation for the hearing. Some of the administrative law judges require briefs. Some of attorneys are very used to writing a brief so that the judge knows what we're going to be arguing and there are no surprises, whether there's work in the file or anything that we need to clean up. Opening statements, some judges require them, some don't. Either way, whoever is representing you at that table where you're all applying, it's very important to have a good theory of a case, good opening statement, solid medical records, and a brief to support all of that together. I've taken a copy of a screen right now, Social Security, at the hearing level, not at the lower levels. So you have your initial level, you have your reconsideration level, and then if you're denied there, you request a hearing in front of an administrative law judge. If you are denied at the hearing level, this is as a sidebar, then you have the appeals council, which is in Virginia, and then after that you have federal court. So almost every attorney can go to the appeals council. Not every attorney goes all the way to federal court. And representatives that are not attorneys will be very happy to represent you at a hearing level. But then if you get denied, you want to make sure before you have any kind of representation that they're able to take you all the way if you need to. That would be my advice. But here's a flash picture of what they have electronically. Once you file your request for hearing, it takes about 30 to 60 days. Where they're supposed to put all your documentation from your lower levels up to an electronic file. This electronic file you have access to as a representative or an attorney. I don't believe clients on their own have access to it because you have to apply and go through, for privacy purposes, you have to make sure that they know who you are, and it's a little bit detailed. But once you have this up, you're able to pull up any case that's at the request for hearing level. All of your medical earnings, all of your medical records are there. All of your earnings records are there. All the jurisdictional requirements are broken up, and that's a fancy word for saying where you filed for benefits, have you moved, what office takes your case. All the non-disability issues are there, and those are all the plethora of paperwork that you receive with how do you feel, have you improved, what do you do, where do you live, who does the grocery shopping. All that appears in these records. So when you complete those forms, you better believe that they're going to come back to Hatch at the hearing level. And I have 2 minutes left. So non-disability areas, disability areas, they're all broken down. That's where you submit your brief, your argument of the case. And that gives you a good indication of what you look on. You click on the particular things and your whole entire file shows up. It is real time. Once it's sent in, Social Security judges are looking at exactly the same thing you are looking at. Okay, this is my last slide, and this talks about the several levels I just mentioned. The initial, reconsideration, your request for hearing. If you lose at your request for hearing, your appeals counsel, then you have to file, and you have a right to file at the United States District Court in Florida. It's the Southern District. The criteria for evaluation using MS is listings, and this is where you have the 11.04, the 11.03C, and then you can do with motor functionings. You can also go into visual impairments. You can also go into organic, which is what they were talking about with cognitive. However, it's important to know this list is not all inclusive. This list is only really talking about putting it all together now. You have visual, you have motor, you have mental, put it all together in your brief. So we're available for any questions. And my email, if anybody does not get to ask questions, is Lisa, L-I-S-A, @gglaw.info. Thank you.
Well, thank you, Lisa. I forgot to give plaques to both Rick and, well, I could give it to Lisa now too. So we want to give them their appreciation plaques. Thank you to both of you, Rick and Lisa. Thank you. Thank you. Thank you. And before we get into Q&A, I just got some good news. Dr. Jack Burks is going to wait till after the program. For anybody that's got those questions to do with neurology, after the raffle, he will come up here and he will take your questions for those in the audience. We cannot do this live, but those in the audience that you want to come over and you have questions for him, he will be here to answer your questions. Great? Good. Now who's got questions for these guys? Ah, there we go. Okay, wait. I'm only here right now by myself. Oops, I'm in the spotlight too.
Hi. My question's for Lisa. I just wanted to know, I currently work full-time, and just wanted, oh God, now I can't remember what my question, what it's a relevant period is for 15 years after you stop working, that they look back for how much you make and how much you would get for disability? Or is that not?
Okay, so the relevant time period for how much you make, when you see that slide that shows your earnings record, is this better? The question was, what is the relevant time period that they look for the time period of the work you did and the amount of money you made. So the amount of money that you made is over a lifetime. The amount of work that you performed is 15 years prior to the date you became disabled. The date you became disabled is not necessarily the date you apply or the date you were diagnosed. It really correlates to the date you last worked. So the last time that you worked full-time, earning 40 hours a week, that's for Title II, which is one of the type of cases. For Title 16, which is when you haven't worked and put enough to bring you above the poverty line, then they still consider work activity, but the date that they consider your onset date is always your application date, regardless of when you worked. Does that answer your question?
Okay, Marie's got a question on the other side.
This is for Dr. Harris. Is Neuro-Psych evaluation typically covered by Medicare?
Yes, it is. It is a standard covered charge under Medicare. Absolutely. Yeah. I'm sorry?
I lost it, sorry. The other question.
We can evaluate that. And Medicare will pay for it. And then we can turn it over to Lisa and we can get you disability.
Do you have to have a referral from your neurologist?
No, you really don't. Psychologists under Medicare, if they're a participating provider, are independent practitioners, so that we would actually do what we call a diagnostic interview and determine the medical necessity of a neuropsychological evaluation, and it would be covered under Medicare. There's no referral necessary unless you have a Medicare HMO product. If you're strictly Medicare, you're good to go.
And Lisa, this is for you. You mentioned at the beginning that you would try and talk about Social Security reviews, and we didn't get that far. Can you speak to that?
Yes, I didn't get that far, and I apologize. Thank you for bringing that up, because I didn't really think anybody was being reviewed. But there is there's a big movement right now to review candidates, whether or not they're on disability, for 5 years or 10 years. It used to be that they were really reviewing people over age 58. Now I'm seeing people age 62 be reviewed. It's starting mostly, I believe it's in Tennessee, but we're seeing it in Florida also. Recently I had 3 people that were being reviewed. It normally goes like this. A review goes with Social Security sending you a letter. Please send us all the updated medical records, the treatment forms, so that we can request these records and sign releases. Always cooperate, never say no. If you're not in treatment, that's the biggest problem. So I strongly urge everybody to continue treatment. Treatment can even be, for my purposes, twice a year. But you want to make sure that you continue. And what you have to show to be able to continue getting your benefits is that your condition has not improved. However, that does not mean, by definition, you will be discontinued benefits. One of the flags that I would urge everybody to remember, if you get reviewed, you only have, if you get reviewed and you get discontinued your benefits, Social Security then requests your records and determines that you have improved and you are no longer disabled. You only have 10 days from that letter to appeal and continue receiving your payment. Continue receiving your monthly. There's a double-edged sword with that. If you continue receiving your monthly benefits while the review process is ongoing, okay, and you lose your case, you will be charged with an overpayment, another trapdoor. So that's on a case by case, and I would be happy to discuss it, but that is an issue. And one of the big flags that trigger review is when you do not have medical treatment and they send you this routine letter, they will flag you, or when you have any earnings under your Social Security case, or if you're an SSI recipient only and you qualify as financially needy. And we do have many, many people where they win a little bit of money on the lottery and they send their Social Security number in and they collect money that will trigger them out of the program and ineligible. Okay.
Question over here.
A quick question. I had a psych evaluation about 10 years ago, and I had one about 3 or 4 years ago. How often should that be updated, especially for disability reasons?
Well, for disability reasons, they really don't care about any day prior to the time that they're deciding to review you. So if you had an eval 3 years ago, fine. If they review you today, you better get another eval immediately. That would be my suggestion, because you're just starting to build, and the trigger is not that you've gotten worse. The trigger is that you're the same and you have not gotten better.
I have a question over here.
Sorry, I couldn't hear you. Yes, sure, absolutely. As long as I need to stay, I will. Okay? Somebody? Yes.
Yeah, I was wondering if I have a partial military disability, can I get a Social Security disability as well?
Are you currently receiving both?
No, I'm getting a partial military disability. I was just wondering, can I also get a Social Security disability?
Yes, the requirements would be different. Long or short-term disability is a private contractual agreement that you have between your previous employer or your insurance company. It used to be that you could double dip. It used to be if your long-term disability policy was from many, many, many years ago, there was no offset. Today, they may decide, I have to read each policy independently to see whether or not there's an offset. The benefit of it is, oftentimes, the long-term disability is very happy because they collect a certain percentage of your retirement to pay you back. You pay them back, your future may or may not be untouched, and the Medicare that you get, or the Medicaid, but in this case it would probably be Medicare, is unaffected by your long or short term.
This is for Dr. Harris. Have you ever had a patient that had lost the ability to cry?
Have I ever had a patient lost the ability to cry? Yes, absolutely. One of the symptoms of some cognitive deficits are an inability to express our emotions. Also with some of the psychiatric disorders, such as depression. It's not uncommon to have a flattening of a mood, and it is a symptom, could be a symptom of depression and inability to cry, absolutely. And therefore, that's why it's important to have an accurate assessment to understand what that's about. Is it a psychological issue? Is it a cognitive issue? There are some side effects with medications too that blunt our affect, where a range of experience of emotions are flattened. So it's important to have a pretty comprehensive assessment to assess that.
I have a question here.
Talk into the microphone, please.
Can you hear me now? Yeah. Yes, so I have a question for each. The first is on the Social Security and of process understanding. And I know we're supposed to not ask individualized personal questions, but I guess we can't help it. So when I had applied for my Social Security, went through the process, and they did the physical evaluation, all the gazillion questions over the phone and all the forms and et cetera, et cetera. And I always followed up, and then I found out that they were done and they had made a decision, and I called to find out, and they said yes, they had made a decision, however, it had gone for audit. And then, and so they wouldn't know anything until the audit was done, and I would receive a letter stating whether the Social Security was approved or not once the audit was done, and they said that could take up to 3 months. Now, the very next day, I received a large chunk of change in my checking account from Social Security. So does that mean I was approved, or did they screw up?
I love it. I really love the question. You did not play lotto, did you? Yeah, you were most probably approved, and then somebody must have picked it up for whatever number of reasons. We're seeing a lot of that. And as long as your medical records are there, As long as everything is, it's fine. What happens is once in a while, it's like a quality control. Did you get approved because you knew the person at Social Security? Was there a relationship? Is it just random? You know, it was maybe a little too quick for somebody's comfort zone. But if you were paid and you haven't committed any fraud, you probably will get your decision after your payment. Congratulations.
And then my other question is about the neurofeedback.
Yes, please.
So I didn't understand pretty much anything you said when you were talking about it.
That doesn't surprise me.
So I didn't quite understand. So if you could please explain a little bit about that, and is it a benefit, and what is it, and why should we do it?
Sure. Just real briefly again, what neurofeedback is, it's a form of biofeedback. So what we do is we use your EEG. We're measuring the electrical activity of the brain. We place electrodes on the scalp based on symptom profiles. So for example, if we're helping with sleep, the electrodes will be placed different than if we're helping with focus and attention. We measure the electrical activity of the brain. We program into software targets that we want your electrical activity to achieve. We don't want your brain to produce any instabilities, and we want the brain to produce optimal performance, optimal functioning. Those are two parameters. When your brain achieves that, we feed that back to you. So what we're doing is we're feeding you back to you your own brain's electrical activity by watching a movie. The movie screen pulsates and mirror images brain functioning. It's very similar to when we train our dog to sit. When it sits randomly, we give it a treat. When your brain randomly produces electrical activity of stability and optimal brain functioning, we give it a treat. The movie screen is big. What happens with, and what you experience in every session, is a sense of being incredibly calm and focused. Athletes call that being in the zone. That's the goal of every treatment. We do adjust frequencies to get you to achieve that. That's what we call the optimal reward frequency. The next thing, what's the benefit? We know very clearly. The American Academy of Pediatric Medicine has recognized neurofeedback as a level 1 intervention for attention and concentration, meaning that's equivalent to or better than medication for attention and concentration. We've had incredible success with sleep disorder, migraine headaches, attention, concentration, and memory. Because what we're doing is we're teaching this brain how to perform better. Was that helpful? I'm sorry? Where do you get neurofeedback? There's this incredible thing called Google. Just type in neurofeedback. There's we have several neurofeedback offices. We have an office in Dade, couple in Broward, where we're doing the neurofeedback training. The exciting thing for this too is a little sidebar. It was interesting. Am I getting the? Sorry, I just got the hook. I didn't get it earlier, Stuart.
Okay. Listen, if you have questions
Later.
for the doctors afterwards or the attorneys afterwards, please just see them afterwards. I'm sure that they'll stick around to answer your questions. By the way, you all up there are people out here in the audience that are asking for your business cards. So if you could leave them somewhere later, they would appreciate that. Or again, we'll post that up on the website. But now, our next question.
Yes, all right. This is for Lisa. I know we're getting a lot of information here. For some of us, it's hard to retain everything all at once. Is a lot. But you said that they're reviewing everyone that's on disability, and they're reviewing their disability information. And if we're already on a therapy process and they could see through medical records that we're on a therapy process, will it be stressful for us of any changes, or everything will still continue the same?
Everything will continue the same. When I said that we're reviewing, I didn't want to create anxiety. I just wanted to make sure that there's continuation of treatment. If there is, everything remains the same. Okay?
Okay, we have time for 2 more questions, one from each side of the room.
I
Maria,
have a
you're
question
next.
here.
Hi, I have a question for Dr. Harris. My question really is, how do you know that it's going to be beneficial for you to have the test done?
I'm sorry. Can you talk in the mic? I can't hear you. I'm sorry.
How it's going to be beneficial for you to have the test done, and how do you know that you need it?
How do we know if it's going to be beneficial for the neurofeedback?
Right. And what are the examples that you might need it or not need it? Because it's hard to predict.
Sure. No, I understand. The question was, how do we determine that neurofeedback is beneficial? My experience is all of us can benefit in general from neurofeedback. We do a lot of work with professional athletes. We have a division of our practice called Axon Elite, where I had conducted some research and published my findings with just athletes in improving their attention, their concentration, and athletic performance. So the reality is all of us can benefit from improving our brain functioning. But the important part for us is the first step in the process of neurofeedback is a evaluation, so that we can identify what areas of brain functioning, what symptoms you experience, so we can tailor treatment to everyone's individual needs.
Okay, from this side, firstly, from Facebook, 2 questions. 1, how long does a neuropsychological evaluation take, and is it covered by insurance?
Neuropsych eval can vary, and that's, again, dependent upon what we find. It used to be back in the day, you came in our office and you would be given a full battery, a standardized battery of tests, which was about 6 hours. But now we look at what's going on with the individual, and the assessment can run anywhere from 2 to 6 hours over multiple days, whatever is convenient. And the evaluation consists of very different tests. It's not just one paper and pencil true-false test. There are things that you may be asked to put puzzles together. There's memory tests. There's motor tests. Because we're looking at all of the different areas of cognitive functioning. Most often, if you have Medicare or a third-party payer, such as Aetna, Cigna, United Behavioral Health, they all cover neuropsych testing, as long as there's medical necessity.
Short, quick question for Lisa, and then for Dr. Harris. Lisa, assuming I'm a spouse, assuming my wife has Title II instead of Title 16, is there an income limit that I am hit with before they can take her benefits away?
No. If you've worked and put money into the system in your Title II, resources and income have nothing to do with the claimant unless it's coming from their Social Security number and they're working. No. You can make a lot of money and she'll be fine.
Okay, all right. And then for Dr. Harris, real quick, although this is not MS related, you put an item on there that you treat, which is tinnitus. Same process as you would treat for MS?
Yeah. Just the question was, do we treat tinnitus with neurofeedback? Tinnitus is ringing in the ears. We've had some really good success with it. And again, it's a different protocol, but yes, we've had some very good success with tinnitus. Yep. You're welcome.
Question from this side of the room. The gentleman wants to know if neurofeedback can help with depression.
Yes. Keep it simple, right? No, it can help. And again, one of the things we need to understand is that depression's not one disorder. Although if you look up in DSM-4, DSM-5 today, it's one disorder. But there are many symptoms that contributed to depression, and we help subtype that. Is the depression one in which you're not motivated, you can't get out of bed, or you agitated, or you can't fall asleep? Is your appetite bad, or are you gaining weight? So depression is more than one disorder. So that's where the neurofeedback can be extremely helpful. The other thing, that neurofeedback, if you improve brain functioning, if you get that brain to function better, medications work better. So it even can potentiate the antidepressant medications, the anti-anxiety medications, and the mood stabilizers, because we're getting the brain to process better.
Before we go to that side, I have another Facebook question for you. Person writes, I'm receiving SSDI based on my years working. Could this amount be changed? Could this amount be changed based on my ex-husband's income during the years we were married?
That's a loaded question. There are disabled widows benefits. If you have an ex-spouse and you're over age 50 and a person died within the 7-year window of you turning age 50 and you're disabled, then yes. But if it's just an ex-husband and you're collecting under your own income, no. And while Stu doesn't realize, I forgot to mention when you were talking about depression, you can win a Social Security case on depression alone. You can also win a Social Security case on side effects of medication alone. So if a medication helps you and it's improving your condition, however, the side effects are so severe that it prevents you from doing substantial gainful work activity, and you can prove that through documentation, you can also get a fully favorable decision.
Any questions on this side?
Yeah.
This is a question more about the ADA law and what you should and shouldn't report to an employer when you're employed. My daughter has MS, and the question came up, what should be reported on an application when you're in the job or applying for a job? What should you reveal to your employer regarding your MS and its potential disability or your inability to do a job? Because they may screen you out and ultimately say, hey, you know what, this person's got MS. Don't hire them.
Okay, so there are employment lawyers, like my practice is specifically dedicated to Social Security disability. And I do have friends that practice ADA law specifically and exclusively. I'm not an expert in that field, but I will tell you that if you have an ADA concern, you should make sure that you're well aware how you respond to questions. I believe it only affects employments with 50 employees or more, 50. I also know that you cannot double dip. You cannot want special accommodations through ADA and then try to get Social Security disability because you're disabled. So they work completely diametrically opposed. One can help out the other in terms of attorney giving feedback to the other. But if you want to work and you're able to and you need special accommodations, then you need that aspect of the law as opposed to what I'm talking about today. Does that help? Got it.
Okay, the last question from this side. Person wants to know if her husband is retired and she needs to file for Social Security and she's never worked, can they still file for Social Security disability based on her husband's retirement income?
Not if it goes above the poverty line. And I think the figures right now for two-home income, I think I wrote it down, it's for a couple $1,082 a month, for an individual $721 a month. And that I read yesterday in the journal that it's going up, but it's established by Congress. It was based on the poverty rates, and it is based on per state. So every state is different. For example, these are Florida numbers, and New York may be different. It is different, it's higher. Right now, for 2014, an individual couple would have to be above 721 to not qualify for SSI. I'm sorry, an individual. And a couple, it's 1,082. So if you, for example, are in the poverty line and you have a spouse that earns or brings income in of $720, technically that $1 of need will qualify you for SSI as well as Medicaid, which comes with the SSI. One for an individual in a household.
Last one for Maria.
Yeah, Maria, we have people in the front table that we haven't meandered to.
My question is, can you only get SSI for a certain number of years and then they transfer it to Social Security versus the SSI if you reach the full retirement age for SSI?
Okay, so what happens is that the monies you pay into the system, they expire. So your quarters of coverage, and a rule of thumb is if you've worked 5 out of the last 10 years, you're insured for receiving benefits under your earnings. But if you have not worked 5 out of the last 10 years, but you've worked for 20 years prior to that, and you have a nice retirement, they will transfer you at the age of, I'm not sure if it's at 62 at 100%, but they will transfer you when they can take you out of one set of books to another. It's done internally. So it's not as though, they just switch you from one program to another, whichever one will give you the higher number.
So it would not necessarily be the same amount? Just say you get, say, $500 from SSI, would it be $500 on Social Security, or could it be a higher amount?
It will be the number that you're entitled to based on the work that you performed and what you have paid into the system. So you know how we used to get, and I think for the last few years we haven't gotten a printout from Social Security, the green slip, and it says in the back, that's the number that you're entitled to at 62, that's the number you're entitled to at 65.
But I thought they used what you'd already paid in to determine what amount you got from SSI.
Right, but that would be if you're not covered and you're not insured. If you last worked longer than 5 out of the last 10 years, then those numbers don't help you today. They will help you when you're eligible via age.
Okay, so you're saying 5 out of the 10 years when you are actually want to apply for your Social Security.
You want to apply for Social Security disability as soon as you know and feel that you're not able to work and it's going to continue for 12 months or more.
No, I understand that, but I was just talking about after the SSI, when you, let's just say 65, you qualify for regular Social Security?
Social Security will do the transfer on its own internally, and you'll just see a bigger check.
Thank you.
Okay.
Thank you. Listen, everybody, let's thank them first. Thank you. You know, we're going to be doing a Q&A out of Orlando, that's a live webcast also, and that's going to be on November 22nd. So we're going to have up there a neurologist, a nurse practitioner, a psychologist, and maybe we'll add a disability attorney to that too. But you can go online at that time, by just going to our website on November 22nd. Everybody will get notices about it, and you can be part of the Q&A live. Your questions will be asked live, okay?